lucky to have our first speaker, Dr. Kumar, doctor here, who has been doing as a doyen in refractive surgery. He's been there right from the inception of refractive surgery in our country. And he's going to be, heads the Kumar Dr. High Hospital and is a great entrepreneur. And he's going to be talking on update on epithelial mapping and relevance in refractive surgery. And it's a very important topic because a lot of decision takings are now related to epithelial mapping. So on to you, Dr. Kumar.
Good morning, everybody, and thank you, Chitra, for the nice introduction. So I'm going to talk on epithelial mapping. As rightly said, I think Mahipal and Chitra are doing LASIK before I started. I started in 1999. I think they started in 97 or 96.
97. Yeah.
97, yeah. So that time we used to do -15, -14, and we had a head of 110, 130, and 160 on the microkeratome. And we never looked at the epithelium. And of course, things have changed a lot after that, and now we are at this stage today. So there has been an evolution even in the mapping of the epithelium itself. Previously, we had bad ultrasounds, and there was another machine called the ARTEMS, which was also looking at the epithelial mapping. But over a number of years, even that has changed, and now there are different modalities that are now available. So we have an OCT-based epithelial mapping, and I also have the Anterion, which also does epithelial mapping. So this has now become a necessity tool. It's like topography for all our refractive patients. So yes, when you have an ectatic cornea, which just looks like your other picture, we see a proper ectasia, there is no confusion at all. But the problem actually happens when it's subclinical and you are really not sure whether you should touch that patient or not touch that patient. So you can see the other image on the other side, the right side, where you can actually see a little bit of steepening inferiorly. So now OCT-based devices are at a wavelength of 830 with a width which covers almost central 6 millimeter and above. It covers the anterior and posterior curvature of the cornea at the same time and it's quite repeatable and quite reliable as far as the training is as far as the scanning is concerned. So it is a need of the today, that screening of every candidate, and when you have doubt, don't even think about it, you have to look at the corneal epithelium because it can unmask any irregularities which is there. It's very important to look at the epithelium besides the actual map or the topo map that we are looking at routinely. So this becomes in our routine checkup when it is pre-op. Of course, we have to do topo, tomo, ocular wavefront. Of course, you have to look at the other surfaces. But if there are any irregularities at the epithelial level, which has to be looked at because it will show an impending ectasia. So again, here another picture, you can see a good epithelium, 56, 50 all around, smooth, nothing to worry. This is a straightforward case. So now the role of epithelial mapping has become quite important. Irregular epithelium remodeling, especially when there is a regression, okay? So if a patient has undergone myopic LASIK or hyperopic LASIK and there is some amount of regression, just don't go ahead and do a surface or lift the flap and do a treatment because the epithelium could be remodeling at that level. So if you have a thicker epithelium than the pre-op epithelium, then some microns or some refractive error has come from the epithelium itself. Like the apical syndrome following hyperopic LASIK, very important to look at the center. Again, previous topographies and corneal thickness have to be used in your reanalysis, and direct measurements of the epithelial thickness is necessary, which can be customized in treatments today's world. So nowadays we have smart pulse or surface treatments possible. The epithelium you don't need to remove with any alcohol or mechanical. It is directly done by the laser itself. So you can see here just a little bit of comparison between the OCT and the Anterion, pretty close. So you can see a superior 59, and here we have a mean average of 51. So they are quite matching. You can, in Anterion, you can get from 0 to 2 and 6 to 7 mm. So it covers about 7 mm of your central cornea completely as far as the thickness of the epithelium is concerned. I'm just showing some examples. This is an abnormal looking inferior steepening. On the pentagram, we have the bad D, and the patient wants LASIK. So now the question is, what are you going to look at this case besides the other things? Again, look at the epithelium, very, very smooth, regular, no steepening in the area of the steepening, so then nothing really much to worry, and you can go ahead and do that. Another case where again, superior abnormal looking cornea, again a bad D on the pentacam, and the patient wants refractive surgery. Again, we look at the epithelium, very smooth, really nothing much to worry. You can still go ahead and do this. Now, there are no red flags in this case at all. So you can see that everything is smooth. Paki is 546. But if you look at the Berlin map, look at the other one, you get a central red area, and the Berlin thing is going down. And the bad D is 2.45. So whenever you get this, don't worry, because look at the white to white. The white to white will be 10 and something. Then you will get a central red area on the pentacam. And this is a flaw in the pentacam. It's nothing to do with your posterior float at all. So this is just to tell you that if this happens, make sure that you look at very thick corneas. A small white to white will appear like a bad D on the back surface of the cornea, and you will get worried about it, but really nothing much to worry. And again, you look at the epithelium in the same patient, very smooth, really nothing there. So you can still go ahead and do your laser surgery that you want, LASIK or lenticule or whatever you wish to do. Now, this is another suspicious case. You can see a steepening, and the patient had 6/9 vision. And you'll think that this is a subclinical case. But when you look at the epithelium, so you can see this, the left eye, the other eye, the steepening is not in the area where the steepening is on the pentacam. So it's in the opposite direction. So what would you do in this case scenario? What I think is, I did not touch this patient at that moment. You can do surface treatment. Either you give some cyclomune, cyclosporins, you do some surface treatment, and then re-evaluate this patient, and then you can think whether you want to do, or you can, some doctors can do an extra on this. They go ahead and do a surface extra if necessary in case. But as you notice, it's not matching. So this can be looked at, that this could be just a little bit of epithelial modeling in another area, not in the area where the steepening is really there. Now, this is another interesting case which we discussed the other day. I think Chitra was there in the hall. This is a 25-year-old. All of us who do lenticule surgery, you see that it's a 3.5, 1.5 SIL. And here is a straightforward case. This is the right eye and this is the left eye. And I did lenticule treatment for this. Now, what happened was, patient was very happy with the right eye. But patient kept complaining about the left eye. And the lenticule surface, the lenticule surgery was smooth. Everything was fine. Even after 1.5 to 2 months, the patient complained of the left eye vision. So this is a pre-op epithelium, as you notice. The right eye and the left eye, everything is good, nothing to worry. But don't forget it's lenticule surgery, and this is the pre-op epithelium. And what you'll notice in the post-op epithelium is this. So this is the right eye, and this is the left eye. So you can see that there is epithelial remodeling in a lenticule procedure in one eye, and that can be the cause of patient's unhappiness in quality of vision post-op, even after a month, month and a half. So this is what we got in one patient, which was quite surprising. I had a discussion, actually, I think Chitra was present that time, and which was decided that this patient, of course, we treat with cyclomune surface, even do a punctal plug, and then go ahead and treat this patient. So this is just a little bit of few cases that I had to discuss. So in conclusion, no doubt that epithelial mapping is a need of the necessity today. We have to look at every case with epithelial mapping. If you want to do retreatment or regressions or anything like that, and you want to do a surface treatment, you need epithelial mapping. It will also unmask any stromal irregularities and makes ectasia prediction and management quite easy and approachable. So it ultimately, surface treatment becomes much easier once you have this tool of epithelial mapping. Lots of references here. Thank you for your attention.
Thank you, Kumar, for lovely videos and lot of important points which came through. That particular case of Smile, which had that kind of epithelium, I would primarily think whether it's a dry eye status, which is the issue, and evaluate it and treat it, and sometimes that could be the solution for that kind of epithelial irregularity. Shreyesh, you saw that video, which you didn't see. A 3.5 Smile procedure, and he had some epithelial hypertrophy on the thing. So I would think primarily it could be a dry eye. There was no regression in that patient. So beyond that, would you do anything actively? Because only epithelial map is showing some issue. Patient is not visually disturbed.
So the question here is, all of you who are doing lenticule procedure, we normally tend to not look at the epithelium, even preoperatively, because everything else is fine. So here the question is, have any of you done a post-op epithelial mapping on lenticule patients and noticed anything different? Because you removed a part of the stroma, does the epithelium try to compensate for that loss or whatever? What is your opinion of all those who are doing?
Remodeling.
There isn't a lot of epithelial remodeling. What is basically wrong is that the basement that gets wrinkles. So that is the thing, that is what actually causes a slow recovery of vision and the contrast going down.
Yeah, so,
But you have shown,
no, so this was 1.5 months. So I understand what you're saying. So nowadays what we are also
so
doing
for
where the
that,
patient is,
you need to do an OCT to kind of look at the NHT OCT. You have to see the where it is, because the plano-convex
Yeah.
lenticule doesn't fit that well.
Thank you.
The
Thank you, Dr. Kumar.
compensatory epithelial hyperplasia for regression itself happens very slowly and over a long period of time, sir. Very often, if it is in the early post-op, sorry, this is some echo. If it's in the early post-op, it's possible that during the initial surgery, you might have had some back end, some loose epithelium, some erosions in that, which while healing has temporarily caused a heaped up epithelium. And that's possibly why there is no refractive effect. If it was a long-term compensatory epithelial hyperplasia, we are likely to have.
so patient is just unhappy with the quality. That's what is the.
Thank you very much. Yeah.
Yeah.
Gaurav, it's your turn. तूने बोलना है, मैं बोलूं?
Correct. Thank you.
So we go on to our next speaker. You can have your tea maybe. You ran, huh?
अब तू बैठ.
Okay, okay.